We now continue to the configuration of the provider-initiated section, which is slightly easier to configure than the patient-initiated section. The populations in provider-initiated programs represent populations that are at high risk of TB disease and stand to benefit from systematic screening and a subsequent cascade of care. The menu shows 3 subsections defining the populations reached as a priority by provider-initiated programs, namely household contacts, people living with HIV on ART, and high-risk groups, each with specific subgroups. These populations all follow a similar structure when the population size is determined, followed by the characteristics of this population with regards to TB infection and disease. Users can then apply a care cascade applicable to that population, including coverage and algorithm selection for screening, diagnostic method, treatment, and prevention screening and treatment. For each population in provider-initiated programs, the user will provide inputs for and configure or define a population in terms of 1. Demographics, 2. TB characteristics, which comprise the proportion of the population with TB infection and the proportion of the population with TB disease and the proportion of active TB cases that have pulmonary TB, noting that the extrapulmonary TB cases are handled in patient-initiated programs only. 3. The coverage of TB screening. 4. The screening algorithm and diagnostic method used. 5. The proportion of TB disease found that is linked to appropriate treatment for TB disease. And 6. The proportion who received TB preventive treatment previously, and among those who are eligible and have not received prevention therapy previously, the proportions receiving prevention treatment presumptively or following a test for TB infection. These population structures and user editors are the same for all provider-initiated groups with a few high-level differences, which we will highlight and discuss at the appropriate place. We'll start with the household contact populations. Within the household contact provider-initiated population group, there are 3 subgroups: children 0 to 4 years, children 5 to 14 years old, and adults 15 years and older. These distinctions are necessary due to variations in their screening algorithms and in the criteria determining eligibility for preventive treatment. We'll come to these details shortly. The first tab, Demographics and TB Characteristics, is where the user specifies and defines population sizes and TB characteristics in the household contact populations. Here, the user sets the average household size, the proportion of the household who are 0 to 4 years old, and the proportion of the household who are 5 to 14 years old. Household contacts aged 15 years and above are defined as 1 minus the sum of these 2 proportions. Next, the user defines the proportion of children under 5 and adults among household contacts of index cases who have TB infection. For 5 to 14-year-old children, the model design assumes that the same value as for children under 5 applies. The user next defines the proportion of children under 5 and adults in households of index cases who have active TB disease, and among these patients the proportion with pulmonary TB, noting that the model design assumes that provider-initiated programs focuses on pulmonary TB cases and that extrapulmonary TB is adequately handled in the patient-initiated program section of the tool. For 5 to 14-year-old children, the model design assumes that the same value as for children under 5 applies. In the Index Cases section, the user provides inputs to define index cases whose contacts need to be evaluated for TB disease and potentially for TB infection, depending on the eligibility criterion for TB preventive treatment being applied. All new bacteriologically positive TB cases are index cases and their contacts are generally followed up, following WHO recommendations. New bacteriologically negative TB cases may be infectious, and their household contacts can be traced too, depending on a country's TB policy. The benefits of providing prevention treatment for contacts of bacteriologically negative cases who don't clearly have active TB is less clear. However, if national policy dictates it, then a proportion of new bacteriologically negative TB cases can also be included as index cases. These 2 rows are calculated from the inputs of the total TB notifications target and the distributions defined in the Define TB Case Type editor. They are grayed out from editing. Next, in the Household Contact Tracing section, the user defines the proportion of household contacts of index cases that are either bacteriologically positive or negative and screened or evaluated. This proportion will be linked to the household members of new bacteriologically positive TB cases as is strongly recommended by WHO, or to the household members of new bacteriologically negative TB cases if such a policy is in place in the country. In the Screening, Treatment and Prevention section, the user defines the care cascade, comprising editors for screening, diagnosis, treatment initiation, and TB prevention for those eligible. Regimen allocation is handled in a subsequent section of the target population overview video. Let us select the under 5-year-old age group from the age group selector. The other age groups work in the same way. The user first specifies the TB screening proportion. This is the coverage of screening amongst the selected group, paying attention to the base year value and the target year value in the final year of the strategy being costed. Then the user must select a screening algorithm. There is a predefined list of screening algorithms recommended by WHO for the given population group. These screening options generally include sequential and parallel screening algorithms. There is also an option to configure a custom algorithm by stating the number of steps in the algorithm, namely 1 or 2 screening steps, and whether the steps are applied sequentially or in parallel. For example, for household contacts 0 to 4 years old, we may select the recommended and default algorithm, CC3.3, which is a parallel screening algorithm comprising TB symptom screening and screening with chest X-ray, with overall sensitivity of 97.3% and specificity of 34.6%. The sensitivity and specificity of the selected screening algorithm is displayed. It is calculated and it is grayed out from editing. These values come from WHO and are the result of systematic review. However, if the options in the list do not align well with a given country's screening algorithm, then better alignment may be achieved by configuring a so-called custom screening algorithm. At the bottom of the drop-down list of screening algorithms, the user can select Custom Algorithm, 1 step, or Custom Algorithm, 2 steps, and then select the single step or both steps of the algorithm. When selecting a single step, the user can see the sensitivity and specificity of the screening algorithm selected. When the user selects a 2-step custom algorithm, the combined sensitivity and specificity is calculated and displayed, and these calculations depend on whether the steps are applied sequentially or in parallel. At the bottom of the tab, several calculated outputs related to the population and its screening algorithm is displayed. 1. The number screened, which is a function of population size, TB prevalence, and the screening algorithm used. 2. The number referred for diagnostic evaluation of TB disease, comprising the number of true positives, which is a function of screening algorithm sensitivity, the number of false positives, which is a function of screening algorithm specificity, the percentage of true positive cases found, which is the proportion of identified cases that are true positive cases, and the ratio of true positive to false positive cases. 3. The number of true positive cases missed, which is a consequence of non-perfect sensitivity. And 4. The number screened to refer to one true case of diagnostic evaluation, which is a consequence of yield, TB prevalence, and algorithm specificity. These outputs enable an evaluation of the performance of a screening program, and the user can evaluate the pros and cons of using a given screening algorithm. For example, the user can evaluate the consequences of using a high sensitivity and low specificity parallel screening algorithm. One of the consequences may be that many false positive patients proceeding to the diagnostic evaluation step, increasing calculated diagnostic costs. The tool is, however, not recommended to be used in isolation of other planning tools for screening programs during the operational planning phase. For that, other methods and tools, including the WHO's more detailed Screen TB tool, can be used. This tool can be found at the link https://screentb.who.int. In the TB Diagnostic Evaluation Editor, the user can specify the proportion of cases referred for diagnostic evaluation that are evaluated with different methods. For diagnostic evaluation, the user is presented with a table listing all diagnostic methods relevant to the population being configured, which are household contacts aged 0 to 4 years old in this case, and a column called Proportion Diagnosed with Method, where the user allocates a percentage against the diagnostic method to define the proportion of patients diagnosed with each method. The sum of the proportions diagnosed by each diagnostic test used must add to 100%, the tool does not handle the possibility of multiple tests being used to diagnose a patient. The rightmost columns show the sensitivity and specificity of each diagnostic test, and the bottom row shows the weighted averages for sensitivity and specificity based on the proportions provided by the user. These are the values of sensitivity and specificity used in subsequent calculations. At the bottom of the tab, several calculated outputs related to the population of interest, for example, household contacts aged 0 to 4 years, and its diagnostic evaluation methods are displayed following the same structure as in the Screening tab. 1. The number who received diagnostic evaluation, which is a function of population size and TB prevalence among the patients referred for diagnostic evaluation from the screening step. 2. The number diagnosed with TB and who are thereby eligible to be linked to treatment, comprising the number of true positives, which is a function of diagnostic sensitivity, the number of false positives, which is a function of diagnostic specificity, the percentage of true positive cases found, which is the proportion of identified cases that are true positive cases, and the ratio of true positive to false positive cases. 3. The number of true positive cases missed, which is a consequence of non-perfect diagnostic sensitivity. And 4. The number evaluated to confirm one TB case, which is a consequence of yield, TB prevalence and diagnostic specificity. These outputs enable the user to assess the performance of a diagnostic evaluation approach, and the user can evaluate its pros and cons. For example, the consequences of using a high sensitivity and low specificity diagnostic method can be evaluated. One of the consequences may be many false positive patients proceeding to the treatment step, increasing calculated treatment costs. The resulting number of diagnosed patients from all provider-initiated programs also impacts the calculation of the number of patients that can be found via patient-initiated programs, as we will see shortly. A large number of false positives in one or more population group from a provider-initiated group may distort the overall contribution to total notifications that come from provider-initiated programs. Identifying and correcting such outcomes is an important part of the validation process, and we will revisit this topic in another presentation. In the TB disease and treatment editor, the proportion of diagnosed cases that are linked to treatment is specified. This proportion should ideally be 100% but could still be below 100% in some countries. The resulting number of patients linked to treatment is calculated and displayed in the bottom row. In the TB preventive treatment editor of all populations in provider-initiated programs, the user configures the TB preventive treatment plan. After the number of patients with a positive diagnostic evaluation in provider-initiated programs is estimated, the remaining population is eligible for TB preventive treatment, either presumptively due to being at very high risk, for example, child contacts or people living with HIV with low CD4 count, or being eligible following testing for TB infection. Coverage must be specified for either presumptive TB preventive treatment or testing, followed by TB preventive treatment if positive. We now navigate to the latent TB and TB preventive treatment editor. The first line of the editor shows the total number eligible for preventive TB treatment, which are those who are at risk and who had their status for active TB disease evaluated. Among these patients, the proportion who received preventive treatment previously, as documented by the user, is automatically removed from the TPT eligible pool. We note that removed patients don't contribute to preventive treatment cost, but do contribute to impact evaluation. And among eligible patients, the user specifies the proportion receiving preventive treatment presumptively, i.e., without a test for TB infection, and the proportion of the remaining patients who receive preventive treatment following a test for TB infection. For example, child contacts are at such risk for TB disease that preventive treatment is given presumptively in most settings. In the method used to test for TB infection section of the editor, the user must specify the proportion of patients diagnosed with each of the 3 types of tests, namely tuberculin skin test, TB antigen-based skin test for the diagnosis of TB infection, and interferon gamma release assay. This proportion receiving infection tests per year, that is the distribution of TB infection tests, is used for costing purposes only. In the TB preventive treatment eligible cases, editor the proportion of eligible patients for preventive treatment that are linked to TB preventive treatment is specified. This proportion should ideally be 100% but could still be below 100% in some countries. The resulting number of patients linked to preventive treatment is calculated and displayed in the bottom row. The output section shows intermediate results that reflect the cascade of care for the population currently selected, including the number screened for TB disease, the number referred for diagnostic evaluation of TB disease, the number diagnosed with TB, and the number initiated on treatment for TB disease. There are also outputs that define eligibility for TB prevention, the number with presumed or confirmed TB infection, and the number initiated on TB preventive treatment. These outputs can be reviewed and compared with service statistics to refine the inputs such as the screening and diagnostic algorithm choice, TB prevalence, and so on, for the provider-initiated population considered. Each of these are available to the costing module to serve as a target population in costing of a budget line or budget lines. Apart from this purpose, the user can also use these outputs to evaluate the configuration of the complete target population component, as is demonstrated in the target population evaluation video. Let's return to the other two provider-initiated population groups. Their editors work exactly like they do for household contacts, except for the inputs that define population size and TB characteristics. The other differences relate to how screening, diagnostic, and TB prevention therapy eligibility is defined, but those differences do not result in interface differences. The people living with HIV and who are on ART section of the component deals with systematic screening among people living with HIV or PLHIV on ART, typically in a facility that specializes in ART services. There are 6 patient groups to represent the most important categories in terms of screening algorithm variations for PLHIV on ART. Each of these comes from the HIV component of IHT, and for each, a distinction is made between those with and without serious illness, and these inputs are required from the user. The 3 groups are 1. Children living with HIV 0 to 9 years old, 2. Children living with HIV 10 to 14 years old, and 3. People living with HIV 15 years and older. For each of these 3 age groups, the user must define the proportion with TB disease among pulmonary TB cases and the proportion with TB infection. TB characteristics are not specified according to severity of HIV disease in the model, although the distinction may be important in some settings. The severity of disease is based on a threshold of CD4 200 cells per cubic millimeter, which is associated with higher risk for opportunistic infections such as TB. Default values are based on CD4 count proportions from the HIV model used by the HIV component. Patients with CD4 count below 200 cells per cubic millimeter are defined by the model to have serious illness. The distinction based on severity of disease is used to configure default screening algorithms, where typically methods with high sensitivity are used for screening patients with severe HIV disease to minimize the occurrence of false negative results. The high-risk group section of the component deals with systematic screening among high-risk groups other than household contacts and PLHIV on ART. Note that these are adult groups only, and the model design assumes that TB services for children 0 to 14 years old are sufficiently handled in the household contact and PLHIV on ART sections. 6 high-risk groups are included in the tool by default, based on WHO recommendations for systematic screening in high-risk populations, including A, strongly recommended risk groups. These include prisoners, minors exposed to silica, and community-based screening risk groups such as general population with 0.5% TB prevalence or clinic-based screening risk groups, for example, people with untreated fibrotic lesions on a chest X-ray. For each of these high-risk groups, the user must state the proportion of the adult population that belongs to the group and must define its TB infection and TB disease prevalence. Note that custom high-risk groups cannot be created by the user, but if users wish to reflect other high-risk groups, for example, clinic-based screening risk groups such as people with diabetes mellitus, people with chronic lung disease, people who smoke, people with alcohol use disorders, people with drug use disorders, people who are malnourished and healthcare workers, or new community-based screening risk groups such as urban poor communities, homeless communities, migrants or refugees or internally displaced persons, they should select one of the available 6 groups that is not relevant for the country and rename it in Configuration Intervention section as shown in the configuration video. All other editors work the same as the editor for household contacts.